Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, Stephanie Desmon talks to Johns Hopkins psychologist Laura Murray about an evidence-based mental health treatment she and others have been developing for 20 years to help people who have experienced serious trauma. This unique concept has most recently been used in Ukraine to help those who continue to feel the impact of the Russian invasion. Let's listen.
Laura Murray, thanks so much for joining me.
Thanks for having me, Stephanie.
So you've been working with mental health issues related to trauma for more than 2 decades. And I'm wondering if you can tell me where a lot of this began.
Yeah, it began very early in my career. Actually, when I was a postdoc, I responded to trauma, the 9/11 disasters in New York, and we had a mission to really roll out evidence-based treatments for kids and their families. I've always been interested in all sorts of mental and behavioral health issues, and that really got me interested in thinking about how do we get more services out there that are very effective to more people.
Because often services are hard to come by unless you have money. Is that right?
Very hard to come by, Stephanie. Very hard to find services in general, but also even harder to find quality services. So what we see in mental health care is if you have access to someone, and very nice if your insurance might actually pay for that, lots of times folks that are licensed actually don't have opportunities to be trained in evidence-based treatments. So what we saw in New York City is we had all these licensed providers, but usually getting a master's in a mental health field doesn't mean that you have access to any evidence-based, science-studied treatments. So there was a lot of feedback of, we're not sure what to do. There's a lot of newly graduated that's thrown into schools with kids, and they were seeing every sort of problem. So it's a real opportunity to understand the system better.
And so you've created, out of that work, you've created this approach that you're used around the world. Can you tell me about it?
Yeah. So before we created the approach, which is called the Common Elements Treatment System of Care, or CETA, a lot of our work globally moved into trying to figure out how to use evidence-based treatments for any population. And so that included making sure they were effective, but also how are we able to do this in Ukraine or in Papua New Guinea or in rural Africa? And so a lot of it was also understanding implementation and who could deliver these treatments and different research questions like that. And one of the things we saw after studying many different evidence-based treatments was that, gosh, this would be hard to scale at a public health level. So we'd have to train a provider in rural Congo in 8 to 10 different evidence-based treatments just to treat everyone that they would see. So if you sort of think about being an emergency room doctor, you sort of have to know everything. And that's in a lot of the rural places we went, this is the situation we ran into. So it felt a little bit unscalable in the public health world, and that we weren't quite going to get there. And so that's really one of the main reasons that CETA came about. Was we thought we really need one system of care that not only treats multiple problems, but also integrates everything else we do at Hopkins with our global mental health group, which is really focusing on assessment, a solid process for triage so that no one gets more or less than what they need. They're triaged to the right person. And then, of course, that person delivers quality care, and then everything's measured to make sure we are making a difference.
You keep saying evidence-based. So just for an example, what's something that's evidence-based?
That's a great question, Stephanie. And I wish more people asked that question. So evidence-based, technically described by SAMHSA and other organizations, is really any program or intervention should have at least 2 very strong randomized clinical trials that are published, peer-reviewed in the literature. And then there's all these details of there needs to be a certain sample size and et cetera. And so before that, interventions are called promising. And then once they become evidence-based, they have a minimum of 2 randomized clinical trials. So our CETA program now has, I believe, 7 randomized clinical trials and then a couple open trials.
What's unique about it?
So we really designed CETA with the perspective of what are the problems we're seeing in the systems out there. And so one of the biggest problems is everything is siloed in our mental health care. So for example, if I came in with substance use issues, depression, and anxiety, I'd have to find 3 different specialists. And so when you think about the mental health care system and the journey I would have to go through, let's say I find one person who knows evidence-based treatment for depression. Now I have to start looking for the next person who knows evidence-based for substance use. And usually there's waiting lists. And so we really thought we really need to work on what we call multi-problem models. And this was already being done in the United States when we developed CETA. So it wasn't much of a stretch. The thing that makes CETA a little bit more unique from other models is that we really boiled it down. We went through a lot of research at the beginning, talking to developers of evidence-based manuals. We scoured the literature and really tried to understand what are the key puzzle pieces or elements that really is going to make this effective. And we narrowed it down to a very small number. The other thing that's unique about it is that it can be taken apart. So these puzzle pieces can be used in different ways. So one of the things that happens in mental health is, for example, Stephanie, one day we might be working on prevention and wellness, but then 6 months later, we're needing more moderate mental health care, right? And then we're fine again. And then we move up into something else, given our changed circumstances. And so CETA also works across those levels of severity, from prevention and wellness to mild, moderate, and pretty significant mental health needs. And that was also very strategic for us, is that we really felt like you needed a model that responded to all of those because humans flow between those quite frequently. And then a few other things. We wanted to make sure there was kids and families and adults being able to be trained and written in a way where lay providers could do it.
And you've been working in conflict zones, I know, this because you feel like this really resonates in a situation like, say, Ukraine, where you are working now. Talk to us a little bit about what the need was and how you were able to sort of respond in the middle of a war zone.
So Ukraine is such an amazing place. We've actually been working there for about 8 years before Russia had invaded about a year ago. So we were working based on the war that was on the more eastern front. And so although it was considered a humanitarian setting, not quite as significant and pervasive as what has happened since then. So it really set us up in a nice position because we already had amazing partners on the ground, great local organizations, a lot of providers that were already trained in CETA. We actually had 4 people that were trained as trainers in CETA. So this was working off of a USAID grant, and USAID really worked with us to build sustainability in country. So we had a lot of that when this most recent war broke out. So it's been an amazing experience. Early on, we had to develop a lot of new systems because this situation was different in the sense that there was a lot of mobile movement. People were moving out, moving from shelters to another. People were in cars, and everything had to be sort of movement-based. And they also are a very technology savvy country, which is different from, for example, if we're in the middle of rural Africa. We were able to use technology a lot more in the Ukraine setting. And what's great is we were able to really put into place this system of care I was talking about. So starting from an assessment time point, we created this QR link because they had to be able to access it. Nothing was in person anymore. Buildings were destroyed. And so you get a link on your phone or a QR code. They could be passing through a UNICEF border or passing into Poland, and there would be a link or a QR code. They could be in a shelter and it could be shared. And that would allow them to request for services. And then we use technology to get a board. And as soon as they request it, it comes to our board and we triage it. We assess safety and suicide. Anyone who does have suicide is moved up to the front. I think one of the scary things about Ukraine has been the very, very high rates of suicide. And I know this is a real interest in the United States too, but we get 50 to 60 new requests each week in Ukraine for mental health services. And somewhere between 50 to 80% of those are saying they want to kill themselves. And you can see within the context there, like they've lost their homes. Many of them have lost their jobs, their bank accounts, plus they've probably lost family members. So the deep sense of just loss and grieving. And now what we're seeing is a lot of people going through this isn't going to be short mentality of like, wow, I've really lost this all and it's not coming back. And so what we see is a lot of really deep hopelessness, which is a big trigger for suicidal ideation.
So how are you able to help?
Well, first, we have amazing people on the ground who, in Ukrainians, their spirit is just so strong and so committed. During the electricity outages, our counselors would go and find like a radio station, Stephanie, just to say, can I work off your electricity for a while because I have someone who's suicidal and I absolutely have to communicate with them today. So very, very resourceful. So I would say first is just personnel. And one of the reasons I start with that, Stephanie, is so many people these days are, I know, working on access with mental health, and there's a big technology boom, but it's really important to keep in mind that there's also a person need here, and there has to be some sort of commitment. And for a lot of people, just knowing that their counselor was going to call them and knowing that someone cared when they felt like they didn't know where anyone else was or if they were alive has been really critical. So the second thing is, of course, we're implementing this system and it's very streamlined now, from the QR code and the link to the assessment, to the dashboard, to us triaging. Unfortunately, there are not enough resources. So we have a wait list now, which is really sad. I think that one of the challenges always in humanitarian settings is people like to talk about mental health, but they don't like to pay for it at the level needed. And so we've seen a lot more popping up of suicide hotlines or self-help things. But the need we're seeing right now in the context of this disaster is much more moderate to significant mental health, some of those high suicide and comorbid conditions. I will say on the positive side, though, once they get into our services, we're seeing the same thing that our research studies show, about 8, maybe 12 sessions. These tend to be 45 minutes to 60-minute sessions, all done via technology and all sorts of technology. Ukrainians are great moving around between Zoom and WhatsApp and Telegram and all sorts of other things to make these sessions happen. And the stories are incredible. Just horrific stories of what people have experienced, and going from no hope to now I have hope. I can see a way forward. I've learned to think about things differently, or I've processed that traumatic day when things were blowing up. And really amazing stories on the clinical side of people getting to a different place. And I think we see that given how busy we are. We're getting 50 to 60 requests each week, really word of mouth, is people are saying, wow, this program changed my life. I will say one other thing, just to put a plug in here. This is all for adults. And you and I know, have talked about kids and youth before on here, and we both have kids. And I think that's a real sore spot in this disaster, that again, kids are in a pretty tricky place and there's not many mental health services for them in Ukraine right now.
I know there's a lot of trauma. I know in the United States too, there's school shooting after school shooting. Are these types of projects something that we can use here?
100%. And it's something that we're really trying to encourage more. It's been shocking to our team being a little more grounded through COVID to come back to the United States and see, quite frankly, the lack of progress in mental health. I think over the last 3 years, there's been a big boom in behavioral tech in mental health. I see a lot more access, but we have to ask ourselves, access to what? And what we hear on both the client and the provider side is it's not quality access, right? We're accessing, again, those folks I knew back in New York where you graduate, but you didn't get any solid supervision, maybe, or you didn't have any access to evidence-based treatments. The average time that someone's in therapy here in the United States is still over a year. And so we really see an opportunity for a program like CETA to come in and decrease some of those wait lists, help providers feel more productive, get them to stick around and stay a little bit longer rather than burn out. We have a really exciting project actually in rural Illinois, and we trained about 25 community mental health providers. They had caseloads of over 100. They had hundreds on their waiting list. They were so overwhelmed. They weren't seeing changes. They're not trained in evidence-based treatments. They just felt like they were churning through. And you can see how providers leave the field. And they were so excited by CETA. They saw it as sort of a hope and a way out. And we decreased a bunch of their wait lists, so much that 3 clinical directors went out and got grant funding to train the rest of their staff because they thought, wow, we're getting quality results, we're changing people's lives, and we're decreasing our wait list. So I think it's a real opportunity in the United States if we can start thinking about mental health a little bit differently.
Do you think there's the will?
You always ask such thoughtful questions, Stephanie. Let me say this. I hope there's a will. I think we all have to be a little bit more comfortable with change. And it's really those early innovators and early adopters that are able to see past this very siloed historical mental health system that we currently have. But I think we can get there.
Laura Murray, thanks so much for joining me.
Thanks again, Stephanie. Have a great day.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmon. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.